Here we go. Let me know. Sounds like you can probably hear me okay. Thank you. And this is the green thing. All right.
Do we need to switch slides?
Oh, here we go. Let's go back a little bit. So first of all, thank you so much for the opportunity for me to share some of Anthem's programs across the 14 states, and particularly my state, Colorado. And we have great snow this year, so please come ski. Um, I have several sort of dots to connect, and they sort of may seem a little disconnected at first, but I will take some time to show how they are connected. As the landscape of healthcare delivery has changed, oftentimes the networks are so different even within the same city, let alone the same state. So has the relationship between payer and practitioner need to change as well. Anthem has always felt that the fundamental pillar of a highly effective, functional healthcare delivery system is built on patient-centered care and partnerships with practitioners, regardless of how practitioners are organized or what they call themselves, ACOs or IPAs or Integrated Health Network, IHNs. Now, this clearly includes aligning the way we compensate providers for care, and as we begin to shift and share the risk and responsibility of patient care so that the best care is rewarded and that payment is based on value, not volume. And you'll hear that word value quite a bit. In order to give you a sense, as I was preparing for this conference, and also throughout last year, the enormity of the impact of cancer care, and not just in Colorado, but I suspect this is true for around the country. Anthem, I sort of asked the question in a little different way. How do our 250,000, what we call fully insured, so Anthem is at full risk for this group of patients, we call them members, from a little different perspective. So you'll see that on any given month, 1% of our fully insured members across all lines of business, large group, small group, and individual, account for 50% of allowed costs. So the little red, and that should be the little tip of the triangle, not in perspective, my PowerPoint skills are very poor, I apologize, account for 50% of allowed costs. That's stunning. That's absolutely stunning. Even in our Medicaid in Colorado, it's probably 2 or 3% account for 50%. So we really looked, and you didn't have to squint very hard. There were particularly three different clinical cohorts, and one of them being patients in active cancer care. And patients in active cancer care accounted for about 20% of that 1%. So in our whole population, there was much, much less than 1%, and yet that cohort accounts for 24% of total allowed costs. Now, most of those costs are surely and clearly based on drug costs. Now so that's a dot, and let me go to a different dot, but I'm going to show you how they're connected. Anthem, as I said, feels that primary care is the fundamental backbone of a highly functioning delivery system. And so for over 4 years, we've actually changed how we pay primary care practices. Over 80% of PCPs, primary care practitioners in Colorado, are under our Enhanced Personal Health Care, or EPHC, we love acronyms, value-based program. And I'll spend most of my time talking about that, sort of the farthest left circle there. The details of the other dimensions are in a slide in the appendix, and I won't go into that. Now, these practices have patients assigned, or what we call attributed to them. And these practices have the opportunity to share in a savings and share in the savings based on a reduction of the total cost of care, by improving their quality, closing quality gaps, reducing utilization, which funds this shared pool, by reducing emergency room visits and potentially avoidable inpatient admissions. Now, the key here, the connecting of the dots for us today, is that patients who are in active cancer care, and we just talked about how they contribute to the total cost, are also attributed to the primary care practices, our EPHC groups. So when we looked at a precedent, and I consider DPP a great precedent, and when we in Colorado, we were the first Anthem market or state to adopt DPP, I brought DPP to our EPHC practices and directly connected for them, because primary care is so busy trying to do the right thing and closing all those care gaps and getting their diabetics and all those measures that we've talked about. Directly connecting the fact that, yes, a DPP program may cost up front against their shared savings, if you will, but this avoids the greater cost of those patients developing diabetes, thus preserving more of their shared savings pool. And the practitioners like the fact that it's an evidence-based program. We've made it turnkey, so it's easy to make referrals. But the fact that it is doing the right thing and also contributing and preserving their shared savings, really, they adopted that concept very, very quickly. So in our opportunity in this arena, though, is that as these patients, with active cancer care, and move from that stage into survivorship and still being attributed to their primary care doc, now the primary care physicians are needing some guidance and guardrails to work with this new, I wouldn't say type, but sort of the new stage that their patient is in. And the fact if I can bring, like I did with DPP, some evidence-based information, some concrete and some examples that we've heard about today of weight management and exercise, so that these patients that are now in their survivorship attribution can have a much more full and clear, defined, collaborative relationship with their primary care doc. That's part of my role. And I think the role of a health plan. So I wanted to talk a little bit about how we've broken glass, I think, in oncology care. Our Anthem's Cancer Care Quality Program, CCQP, another acronym, is a different value-based program. It is totally voluntary, it's provider-facing, and Anthem does provide a monthly care coordination fee to the oncologists. Anthem reviewed the universe of established, so these are not proprietary, we didn't change dosing, we didn't do anything. We looked at the universe of available protocols for each cancer type and selected a subset of them based on highest efficacy, those that are evidence-based, least toxicity, and mostly, but not always, the least costly protocol. And as you know, cancer care is the #1 reason for medical bankruptcy. So when we looked at this program, and we call these subset of clinical protocols our pathway. There's a lot of different pathways out there, but that's our term for it. And should an oncologist decide to use one of our pathway protocols, they will get, in order to achieve that and preserve their margin, so that their staff can still be patient navigators and care coordinators, we provide this monthly care coordination fee. And we've just added in the past 6 months the same care coordination fee if one of their patients goes into clinical trials for precision medicine. So again, we're really supporting that research piece. And so this connection here, this dot to connect, is that what we've been talking about this morning. And I think it's a responsibility of a health plan to share this information with the oncology groups that we have, so they too become understanding of the importance of weight management and exercise and strength building. And should that be incorporated into their care coordination fee, or at least their care manager be aware so they can make those types of referrals. I will have to brag a little bit on our CU health plan. CU, our academic institute, CU is in both our CCQP and our EPHC program, and they're special. They also have a specialist as being a medical home, so I'm very excited. I love working with them. They also have program, and they just have some early results in their cancer survivorship strengthening program, where they have seen some increase in the outcomes of improvements in strength, endurance, fatigue, and depression in cancer survivors. Excuse me, and I've put Ryan's contact information down there if you wish to contact him. And I'll end by saying it's not all about practitioners. We also have members and patients. And Anthem does provide the program called Journey Forward, which is in a conjunction collaboration with several other organizations to provide a common goal of improving survivorship with a care plan that's co-developed by the oncologist, primary care doc, and the patient, and does include some digital reminders and ability to maintain the developed care plan together. So this shared care model allows for cancer survivors to return back to the care of their PCP with a very safe and secure, very transparent care plan across all their practitioners. And the opportunity here is to be sure that weight management and exercise is included, and also to share these kinds of programs with our with our ASO, which is our self-insured large clients as well, to make that an offering. So thank you very much.